Alrighty, so you guys ready? We'll get started. Thank you for bearing with the patience and finally getting this lecture to you. I'm really excited. It ended up being a pretty big project, a little bit bigger than I expected. I thought, oh yeah, let's do a simple one on neurolocalization, be okay. But there's a lot of information out there. There's no one source to what I can find that has a really nice, like you follow this source and you have all of what you need to do a practical exam. And a lot of them are pretty good ones, but there's none that, without going exhaustively into detail, says, okay, you know this information, you're going to be able to do good neurolocalization. So I scoured actually 2 different textbooks, 3 different proceeding notes, 4 other lectures, 2 online sources. So there's a lot of information that I read to kind of gather this together. And this is what I think a practical and meaningful compilation of what you need to know. So if you know what is in these handouts, you should be able to go away from this being able to do good neurolocalization. Now, I made a series 2 lectures, so today's going to be just the first part, and then we're going to finish up and conclude with the second part next Thursday. So, you know, all you guys are here, if you really want to get the full story, come in next time, okay? Now, I remember when in vet school, and I'm sure most of you guys here, especially the veterinarians here, are going to understand when you went to neurology class and you did your neurology rotations, it was a lot of information because you got all these things like the cerebrum and the cerebellum and the brainstem and the thalamus and the spinal thalamic tracts and the spinal cerebellar tracts and the red nucleus and the lateral geniculate nucleus and the ganglion and the gray matter and the white matter, and just after all that you just had swimming, and if you're ready for it, can fry your brain, right? I had to do it. But whenever it comes to practical neurolocalization, you really don't need to know all that detail. It actually comes down to some very simple basics, but we do have to approach it in a very orderly way, okay? And we're going to start by going through what's called functional neuroanatomy. What are the nuts and bolts divisions of the central nervous system that you need to know to say, okay, this lesion is in the forebrain, or this lesion is in the cerebellum, or this lesion is in C1, C5 spinal cord segment. So we can know what our functional neurolocalization divisions are. And from there, know what the functions of each of those divisions are, because functionally they all act to be the same. And believe it or not, there are surprisingly few divisions that we need to know. Once we know those divisions and their functions and the signs that are associated with them, then we're going to start going into what is a neurologic exam. What are the things you do to be able to tell where a lesion is in the body? What are the tests that we do? What do they mean? And in order to make it really practical, I'm not going to just say, okay, here's how you do a neurologic exam. I have 3 really good cases. 2 are actually real life. 1 I had to be a little creative with. But they're going to be really good examples of how you take the knowledge of your functional neuroanatomy and how you go about doing a logical neurologic exam to come down to a conclusion of where the lesion is in the central nervous system. Okay? Make sense? And so, now this here view, it was a pretty good view because it shows how there's a lot of different separations in the brain. We're going to start with the brain, and then we're going to go down to the spinal cord. Okay? So you can see the green part is actually your cerebrum. Then you have your kind of reddish brown area. That's what's called the diencephalon. That's where the thalamus is. Then you have what's called the mesencephalon, which is the midbrain. Then you have this area here that's both purple and yellow. That's called the metencephalon, and that's divided further into the pons and the cerebellum. And then you have your what's called medulla oblongata, which is the myelencephalon. So there's several segments in the brain that are depicted here. But really, there's only 3 that we need to localize because they are all functional similar. So we have what's called the prosencephalon, which is the cerebrum, and the diencephalon. So everything here is called the prosencephalon. Okay. Now here you're going to have the cerebrum, which is the cerebral cortex. Technically, that's called the telencephalon. Then you have the diencephalon, which is the thalamus and the hypothalamus. And up here, you're going to have cranial nerves 1 and 2. So the olfactory nerve and the optic nerve. Second thing you need to know is the brainstem. The brainstem is everything from the midbrain, so the mesencephalon, the pons, and the medulla oblongata all grouped together. A couple things about the midbrain though. In the cranial part of the midbrain, called the mesencephalon, there's what's called a decussation of the nervous fibers, which means they cross right there. So any lesions that are going to be cranial to that, you're going to have contralateral symptoms on your spinal cord or in your limbs. Anything caudal to the midbrain, you're going to have ipsilateral or the same side lesions in your spinal cord. Okay, does that make sense? Okay, good. Now, in with your spinal, with your brainstem, you're also going to have cranial nerves 3 through 12. So all but the first 2 cranial nerves are going to be in your brainstem. And so you're going to have the midbrain, the pons, and also the medulla oblongata. Now, the third part of the brain you need to worry about is the cerebellum. Now, even though this is technically part of the metencephalon, it functions very differently. So from a neurofunctional standpoint, we think of the cerebellum differently. So when we're talking about if it's in the head, if the lesion's in the head, all we need to determine is it in the prosencephalon, the forebrain, is it in the brainstem, or is it the cerebellum? That's it, just 3 parts of the brain you need to know. So all those other details you remember from neuroanatomy, don't need to know. Is it in the forebrain, is it in the brainstem, or is it in the cerebellum? Okay? Next, the spinal cord is even simpler. Okay, there's only 4 segments of the spinal cord that you need to worry about. Doesn't matter if it's going to be in the dorsal root or the ventral root or the gray matter or the white matter or the lateral spinal thalamic tract or the lateral funiculus. None of those matter. All you need to know is it going to be between C1 and C5. So basically in front of the forelimbs. Okay. Is it going to be C6 to T2? That's going to be where the nerves that feed the forelimbs originate. Is it going to be between T3 and L3, which is going to be between the front limbs and the hind limbs? Or is it going to be L4 to S3, and that's going to be the hind limbs to the tail on the anal area? So just those 4 segments. And you just have to memorize these. C1 to C5, C6 to T2, T3 to L3, or L4 to S3. That's all you need to know. Okay, so when we talk about is this lesion here, there, we're going to just those 4 segments, that's it. So really when it comes down to it, the central nervous system only has 7 divisions you have to worry about. In the brain, the forebrain or the prosencephalon, brainstem and cerebellum. And in the spinal cord, is it in front of all the limbs, which is C1 to C5? Is it involving the nerves that go to the forelimbs, which is C6 to T2? Is it between the forelimbs and the hind limbs, which is T3 to L3, or is it involve the hind limbs and the rest of the back end of the body, which is going to be L4 to S3? Okay, so pretty simple, basic, only a few divisions that we have to really worry about in our neurolocalization. And when you get your reports back from the neurologist, if you ever send anything up to Dr. McKillop or I'm forgetting your other name. Oh geez, she's such a great person too, because she helped me with this presentation. She actually sent me to some slides and some cases and things like that for us. Oh, doggone it, I forget her name. Anyway, she's wonderful too. But if you ever get a report from them, they're going to use these same 7 divisions of the spinal cord and this brain to say this is where the lesion is. Okay? Any questions so far?
Michalowski?
Ms. McKillop is Dr. Ed McKillop, and
Somethingowski, isn't it?
I don't think so.
She's an old
Dr. Scores, I think it is.
Sikora. Sikorska is a
No, it's Scorza.
That's right.
She's really nice anyway. She's really great person. In fact, some of her lecture notes is what I used for this thing. Okay?
Nikolowski is a doctor.
It's a doctor of some sort. Now, the nice thing about this presentation is being that I made 2 lectures for it, we can take our time. This would be too much information to put into one lecture that's an hour long, but it's really not enough to fill a full 2 hours, so we can take our time going through some of these slides. So if you guys have questions, let's interact, let's talk about it and things like that, so we can really casually go through this. And I think the slower paced it is, the easier it is for it to kind of sink in and to make sense for us. Okay? Skoda, that's it, Dr. Skoda. Thank you. Yes. Thank you very much, Dr. Skoda. She is wonderful. She really helped me out a lot with this. And she's excited I was giving this lecture. So I told her, once I'm done with this lecture, all our doctors are going to tell you where the lesion is. All you guys have to do is figure out what that lesion is. She goes, that's great. That's wonderful. All right, now let's look at the prosencephalon. So again, this is the cerebrum and the diencephalon, which is the thalamus and the hypothalamus. And even though the thallus and hypothalamus have some fine-tuned autonomic functions and hormonal functions of the body, really it all functions as one. The functions of the prosencephalon or the forebrain or what I call the brain things, the thinking kind of functions of the body. So you're going to get your mentation, which is you're going to be bright, alert, or you're going to be depressed or dull or disoriented. Your learned behavior, so these are going to be things like potty training, familiar places, learning the way around the house, things like that. cognition, which has been the perception of the sensory input. You know, I'm going to be aware of my surroundings. I know where my feet are. I know where that sound is coming from. I can see where this door is over there. I can hear that deer outside in the yard, things like that. Volitional movement. When we initiate movement, it comes from our forebrain. So that's going to be the initiation of voluntary movement. Our proprioception. Everybody remember what proprioception is, right? It's going to be the awareness of where our body, limbs, and parts are without having to look at them. So we have an idea where we are for it. Orientation of the environment. How do we orient ourselves to the environment? Do we head straight on? Do we posture? Do we turn away from it? Our orientation or relative position to the environment is also dictated by the forebrain. In memory, that's one thing we're going to remember our things for. So these are the functions of the forebrain. So if we get abnormalities there, what are the symptoms we're likely to see? Now I listed all these because they're going to be the main ones that you're going to see. And if you know these, you're really going to say, okay, that belongs to the forebrain functions, okay? And I'm going to say that's going to lead you towards, that's where the lesion likely is going to be. I wish there was an easier way to do this, but you really do have to just do a lot of memorization with some of these things, okay? But it makes sense if you think about it. So if we have a forebrain lesion, we may or may not have some or all of these signs. These are just signs that you can see with the forebrain lesion. They don't all show up at the same time, and they don't always come together in the same grouping. But if you have these signs or a combination of these, then you're going to think a lot more about it being a forebrain lesion. So altered mentation, seizures by definition are a forebrain lesion. So if you have a dog that seizure and you know it's in the forebrain no matter what. A head turn. I'm going to go through this in detail, but a head turn means that the ears are level, but the head turns from one side or the other. That's not the head tilt. Head tilt is different. Okay. So if you have a head turn, they tend to turn toward the lesion. Okay. Circling, and the circling is usually large circles, like you're going to be pacing around the perimeter of the room. It's not tight little circles. That's usually vestibular, as a tight circles, but wide circles, and usually they turn towards the lesion. Okay. Proprioceptive deficits, and this is the key, with the minimal ataxia. So the coordination is actually pretty good with the legs, but when you go and challenge your legs and put them in abnormal positions, they don't respond properly. So you have proprioceptive deficits with the little to no ataxia for it, okay? Hemiparesis, which means that weakness or decreased voluntary movement. Now this is going to be contralateral to the lesion. So if you have a left forebrain lesion and you do your proprioceptive, or you see if there's weakness or decreased function, it's going to be on the opposite side. Because remember, in the midbrain, you got that decussation. So you're going to have, from a forebrain lesion, contralateral signs in the spinal cord or in the limbs. Postural deficits, same thing. It's going to be on the contralateral side. Now, typical with the spinal cord, those changes with the forelimb or the thoracic limb are going to be more subtle than those in the pelvic limb. So the pelvic limb changes are going to jump out at you. But the forelimb ones, you really have to look closely and challenge them a little bit more directly in order to be able to pick up on those lesions for us, okay? Hemi-neglect or hemi-inattention, I've heard it or seen it called both things. This means that the animal is only aware of and pays attention to things on one side of the body. You know, if they're going up to a door and the door's on their left, they don't realize that door is there and they're going to walk right past it. But if the door's on their right, they see it and they go in towards it. Sometimes dogs will eat only out of one side of the bowl. They were only aware that there's food on one side of the bowl, and they'll completely ignore food on the other side, even if they're hungry. So this is called hemi-attention or hemi-inattention or hemi-neglect. If you see that, whatever side they're ignoring, the lesion is on the opposite side, contralateral side of the prosencephalon. Head pressing, so going into the corner to the wall, head pressing. Aimless wandering or compulsive pacing are all signs of a forebrain lesion. There's another one. Absent menace, but with a normal PLR. And we're going to go through that when we go through the cranial nerve exams. But you remember that if you have an absent menace, but a normal PLR, there's a prosencephalon lesion on the contralateral side from the deficit of the menace. And neck pain. This is one that I don't really appreciate very much or assign very much, but forebrain lesions can trigger neck pain. It's not always a cervical spinal lesion where you see neck pain. Okay? All right. Any questions about prosencephalon functions and the signs associated with them? Pretty good? All right. Now, brainstem. Brainstem, I think of it as the conduit between the cerebrum, so the memory and the awareness and the brain functions, and the rest of the body, okay? So you're going to just connect the cerebrum with the rest of the body. Now the key is it's not the cerebellum. Cerebellum we're going to think of as separately. So the cerebrum, so the brain functions, are going to be traveling through the brainstem to get to the rest of the body. So we're going to have things like consciousness and mentation be affected because the conduit, if it's not there, you're not going to be aware of what's going on. You have all the cranial nerves except for the first two. So cranial nerves 3 through 12 are going to be originating, the nuclei originate in the brainstem. Gait and motor functions of the limbs are going to be controlled there because it's going to be the conduit from the brain down to the rest of the body. And in the brainstem is where you're going to have some of the more basic functions of the body reside. The brainstem is actually the more archaic portion of the brainstem evolutionary-wise, so you're going to have the most basic functions. So control of heart rate, respiratory rate, temperature, body, blood pressure, things like that. Yes.
That's the lizard brain, right?
That's the lizard brain, that's right, exactly. Vestibular function also is controlled there because remember our 8th cranial nerve is in the brainstem, and also the connections to the cerebellum are going to be in there. So both brainstem lesions, 8th cranial nerve, and also cerebellar lesions can cause vestibular dysfunction. So that's going to be in the brainstem area. And remember though, the nerve fibers in the cranial brainstem, the mesencephalon, are going to cross. So lesions in front of the midbrain are going to be contralateral in the limbs. And lesions in the caudal brainstem are going to be ipsilateral in the limbs. Okay, so we're going to remember that brainstem. Also, by the way, the only cranial nerve that stems from the midbrain, or which is the cranial part of the brainstem, is the 3rd cranial nerve 3, which is the oculomotor nerve. So for the cranial nerves 4 through 12, that's going to be in the metencephalon or the myelencephalon, so the caudal brainstem. So the only one that's in the midbrain is the 3rd cranial nerve. All right. Signs of brainstem lesions. Now, these are going to be basic functions of the body, so they're going to be a little bit more obvious. So you're going to have altered mentation, so disorientation or stuporous kind of mentation. Even comatose mentation is going to be associated with brainstem lesions. Gait or postural deficits, which are usually ipsilateral because most of the lesions in the brainstem are going to be caudal to the midbrain. Your vestibular diseases like head tilt, nystagmus, and vestibular ataxia can be there. I'm going to talk a little bit more in a little while what vestibular ataxia specifically means. Proprioceptive ataxia, so as you're seeing, there's a couple types of ataxia that we can see and define. And again, we'll define those a little bit, but you can get both proprioceptive and vestibular ataxia associated with brainstem lesions. Of course, cranial nerve 3 to 12 deficits, and they're going to be ipsilateral if there's going to be a brainstem lesion. Changes in heart rate, respiratory blood pressure, the autonomic functions of the body. And this is one that, thank goodness, we don't see very much. But if you see it, it's a devastating type of a sign. That's called decerebric posture. This means that there is a complete cutoff or disconnect from the brainstem to the cerebrum. Okay. This here is a picture of what an animal with decerebric posturing looks like. It's called apostotenus, which is extension of the head and neck. You're going to have extension of all the limbs, okay? And since this is in the brainstem, this dog is comatose. You're going to have altered mentation with this. The brainstem is a very small area, the surface area in the body, so small lesions can have very devastating effects in the brainstem. So it's going to be a pretty dramatic change you're going to see whenever there's significant brainstem lesions kind of thing. So if you see a dog that is not mentally aware, comatose or stuporous, and you have extension of all the limbs, then that could be a sign of decerebric function. There's a catastrophic lesion in the brainstem. Okay, thank goodness we don't see that very much. Okay, now the cerebellum, the 3rd part of the brain that we have to worry about. Now the cerebellum is in charge of coordination of the movements, so it's going to be the range, rate, and force of the movements that we see. The cerebellum does not initiate the movement. Okay, so initiates movement is going to be of the forebrain, the cerebrum. The cerebellum coordinates that once the movement is initiated. So you're going to get exaggerated movements usually, or poorly coordinated movements associated with cerebellum. Now the cerebellum also has tracts that involve vision, so you can have negative menace, but still positive vision. Okay, so they're not going to respond to it, a menace effect, but they can follow the cotton ball across the floor. They can negotiate an obstacle course without bumping into anything. Of course, the cerebellum also receives tracts from the balance center, so we can have vestibular dysfunction with cerebellar lesions. Now, since there is only control of movements in the cerebellum, but not initiation of movements, we do not get weakness or decreased voluntary movement, okay? and we do not get altered mentation with the cerebellar lesion. So these animals are bright and alert, and they have the full strength and full coordination, or full volitional control of all their limbs. Okay, they just can't coordinate it very well. Okay. So if we have problems with the cerebellum, what kind of signs we see? It's called cerebellar ataxia. We're gonna get into this in a little bit, which means that we're gonna have usually hypermetric, which means exaggerated movements associated with the limbs. Okay, so they have increased range and force to them, and they many times will have abnormal placement of their limbs whenever they do this. Now, one of the other lesions in the central nervous system that can cause also exaggerated movements is called an upper motor neuron sign in the limb. So you get exaggerated limb movements. The difference between them is whenever it's a cerebellar lesions, they have an exaggerated flexion of the elbows and the stifles. So watch the carpi and the hocks. If you see them, they're doing really big movements, you probably do have cerebellar ataxia, where we have proprioceptive ataxia from the upper motor neuron. Their movements will be exaggerated, almost floppy, but their wrists are going to be not moving very much because their elbows are going to stay relatively extended. Same with the back feet. Their knees aren't going to bend, so their hocks are going to stay fairly good, and they're going to be scuffing and swaying. So the way to tell the difference between a cerebellar lesion and, say, an upper motor neuron type of a sign is the degree of flexion of the elbows and the stifles. So you can have an easier time distinguishing between those. We're going to go through that a little bit more when I talk about the 3 different types of ataxia that we see with the body. We can have intention tremors. Anybody that sees any of the myriad of Dr. Wells's cats that have the cerebellar hypoplasia, when they go to move, again, that's not initiating movement. They can start initiating movement, but they can't coordinate. So you get head and neck tremors. A common finding that whenever the cat or dog with cerebellar hypoplasia or cerebellar lesion goes to eat or drink, they'll bob their head a little bit, sometimes dunking their nose into the water or the food before they can fine-tune that control to be able to eat and drink okay for you. They can do a truncal sway. When they're standing still, and they're supposed to be still, back and forth, they're going to be swaying back and forth. It's called a truncal sway. That's usually a cerebellar lesion. Again, we talked about having a negative menace response, but they still have vision or evidence of vision. And again, this is another big one. When we have a catastrophic thing, is where's the disconnect from the cerebellum to the rest of the body. This is called decerebellate posture. Now for this one, it looks somewhat similar to this decerebellate posture, where you get the opisthotonus and you get the extension of the forelimbs. But the 2 big differences are you're going to have flexion of the pelvic limbs, usually of the hips, and these guys are going to have mental awareness. Remember, the cerebellum does not control mentation, so this dog's going to be alert and responsive, and have flexion of the pelvic limbs whenever there's a decerebellate type of a posture. Again, thank goodness we don't see this very often. Any questions about the 3 parts of the brain, their functions, and the signs we see associated with them? You guys are either sleeping from the post-eating coma, or I'm doing a really good job.
What's the difference between, there's altered mentation in both the cerebrum and the forebrain?
Okay. You're right. So you have both lesions in the brainstem and the forebrain are going to cause altered mentation. So what you need to do is other signs to see where it is. Is the dog pacing with wide circles to one direction or the other? Is the dog having other cranial nerve deficits? So if it's going to be other altered brain functions, then you can say that's all forebrain, okay? But if you have altered mentation, but you have several cranial nerve deficits, then you say those are in the brainstem, so it's probably all coming from the brainstem. So you're going to use other clinical signs besides mentation to say, is this forebrain or is this in the brainstem? Okay? Any other questions? You're right, because a lot of the long paths you have for the body, like proprioception, involves everything from the cerebrum down to the muscles. Okay, so a lesion anywhere in that pathway can cause proprioceptive deficits. So then you use other neurologic exam findings to say, is it in the cerebrum, is it brainstem, is it in the spinal cord, or is it neuromuscular? Okay. So yes.
So can you have an animal that has like cerebellar hypoplasia, but then develops seizures? So then do they have a lesion in their forebrain and their cerebellum?
Correct, yeah. No, when we're talking about lesions, we like to have everything explained by one lesion.
Yeah.
But there are several diseases, especially things like granulomas, meningoencephalitis, or multiple infarcts or strokes, or multiple metastatic brain tumors, or you can have multifocal disease. So you can have clinical signs associated with 2 different areas of the central nervous system.
Yeah.
Those are much more difficult to detect because you have difficult to explain signs with one lesion. So whenever that's the case, you start thinking, well, maybe I do have multiple lesions in the central nervous system. Yeah, but that is definitely a possibility.
Who's Tanner's doctor? Tanner Zimmerman?
Yeah.
What about him?
Because he's always had cerebellar hypoplasia, but he's only started to have seizures, right? So did he develop like a...
I mean, if the cerebellum didn't develop right, there's a chance the cerebrum did.
Okay,
like at Olive has seizures all the time, and altered medication.
And that's just
Severe.
something that just didn't develop correctly when they were...
Yeah, exactly. So
In
something
the
either you
womb.
develop, even if it's a congenital defect of the brain, especially if it's in the cerebrum, you don't always see signs from birth. They can start to show up in the early
Later.
adulthood.
As they develop... Okay.
Yeah, exactly. Especially with seizures. In fact, there's many different causes of seizures, as you know. But if it is a forebrain lesion, the most common is called idiopathic epilepsy, which means that you have a forebrain lesion that triggers seizures, but they don't usually show up until 1, 2, or 3 years of age. They're not seizuring as wee puppies or adolescents. Okay, but the lesion is still there. The abnormality is still there. Okay, now let's talk about the spinal cord. I grouped them into 2 main groups in the spinal cord, and I hope this makes sense for you, but it may make more sense if you look at the spinal cord divisions that I had initially brought up. So first part is going to be the C1 to C5 and the T3 to L3 segments. These are I grouped together because the signs are going to be similar, where if you're going to have lesions in front of the limbs or between the limbs, they're going to have similar things. So you're going to have what's called upper motor neuron signs to the areas caudal to the lesion, okay? So that means you're going to have proprioceptive ataxia, you're going to have some clumsiness to the movements, where they're not going to be able to know where their legs are supposed to be. You can have weakness or even paralysis if it's really severe. And you can have posture deficits, when you challenge your feet and put them in different directions, they're not going to be able to correct or be aware of it as well. So that's going to be upper motor neuron signs. That's also signs of lower motor neuron disease. So what you're going to do to distinguish those is I highlighted them in blue. Does it change the color as well on your handout?
Pink and red.
Okay, good. So as long as it's different colors, so you can tell us. But for an upper motor neuron lesion, you're going to have a long strided, slow gait. Movements can be exaggerated, but again, with minimal flexion of the elbows and the stifles. So they're going to be scuffing along and swaying whenever they move. They have normal to increased spinal reflexes. I want to take a special note for that. Neurologists tell them whenever you're in school, they're always talking is you got to see if the knee reflex is normal, increased, or decreased. Quite honestly, as long as it's normal, it doesn't really matter if it's increased. You know that the spinal arc is intact, okay? So it's only going to be important for know, is it normal, decreased, or absent? So don't worry about it being increased. It's a very subjective thing. A lot of neurologists will wonder, is this really increased or just normal for the dog because it's really excited and so it has bigger responses than you'd expect. So don't worry about trying to characterizing it as an increased reflex. Just say, is it there or is it weak or absent? That's the only really meaningful thing when you're talking about functional neuroanatomy and localization, okay? Sometimes you actually will get increased or spastic muscle tone, so you have good strength, and they can almost have a tonus or clonus type of a thing where they kind of have a repeated contraction and relaxation of the muscles for you there. And this is another one's called the cross-extensor reflex. When we talk about the spinal nerves, we're going to talk about the withdrawal reflex, which means you squeeze between the toes, animals are supposed to pull their arm back, okay? Normally it just involves that one limb. But if the other limb extends, it's called the cross-extensor, that's something that can happen with an upper motor neuron lesion. Doesn't always happen, but if you see with the withdrawal, the other leg extends, then that's called the cross-extensor reflex, and that's an indication of an upper motor neuron sign, okay? Now, that's going to be for the segments that are either in front of all the limbs or between the limbs. So if you have the lesion up in the C1 to C6, all 4 limbs are going to show these signs, okay? If you have the lesion in the T3 to L3 segment, the front limbs are going to be normal, but the hind limbs are going to have all these upper motor neuron signs. So it's going to be...
Can you say that again slowly?
Sure. So if you have a lesion in C1 to C5, okay, all spinal cord segments caudal to that are going to be abnormal, so it's going to affect all 4 limbs, okay? If you have a lesion in the T3 to L3 segment, that's between the front limbs and the back limbs. So only the areas caudal to the lesion is going to be affected, so only the pelvic limbs will show the upper motor neuron signs in a T3 to L3 lesion. Make sense?
Yes.
Okay, good. Got it? Yes.
So I'm sorry, I have so many questions.
That's good though.
So so the cross extensor reflex, if you had a lesion in the C1 to C5,
Mhm.
would it, like you would say you did this to this foot,
Yeah.
would it go back to this foot or would it
No,
go
it's-
up to this?
No, it's the same. So if it's
So
on the
it
thoracic
has to
limb,
be
it's
like
the opposite thoracic limb that will do it.
Okay.
If you do the withdrawal in the pelvic limb, it'll be the opposite pelvic limb that will extend.
Okay.
You're not going to get a cross extensor from squeezing the thoracic limb and have the hind limb extend.
Yeah.
It's the same level
Okay.
limb.
Sorry
Okay?
if that was a stupid
Yeah.
question.
No, that's a great question. That's wonderful. All right, now for the segments of C6 to T2 and L4 to S3. These are the segments that are where the nerves that originate to the limbs are. Okay, so C6 to T2 supply the nerves to the thoracic limb, the front limb, and then L4 to S3 are the origin of the nerves that go to the pelvic limb. Okay, so now for here, you're going to get lower motor neuron signs to the limb for which these nerves supply. Okay, so in the C6 to T2, you're going to get lower motor neuron signs for the thoracic limbs. Now the key is, if you have a lesion in a place, the areas of the central nervous system caudal to that are going to have upper motor neuron signs. Okay, so if you have a lesion in the C6 to T2 area, you'll get lower motor neuron signs to the thoracic limbs, but upper motor neuron signs to the pelvic limbs. Does that make sense? Now, if you have a lesion in the L4 to S3 area, you're going to have normal thoracic limbs because there's not a lesion cranial to it or at it, but you're going to get lower motor neuron signs at in the pelvic limbs. Making sense? I'm sorry, lower motor neuron signs in the pelvic limbs. Now, if you look, the first three criteria for lesions are all the same. Proprioceptive ataxia, paresis paralysis, postural deficits. Those are going to be common to both upper motor neuron and lower motor neuron signs. So the way to distinguish those is where I highlighted these. In a lower motor neuron, as opposed to a long strided slow gait, you're going to have short choppy gait. The gait's going to be much faster than it needs for the rate at which they're moving, so it's going to look really short and choppy. Or if the back legs are going to be like they're dancing, prancing, okay? You're going to have weak or absent spinal reflexes. So the nerves that go to that area are going to have decreased responses. Okay, don't worry about increase, it's going to be decreased or absent, okay? And you're going to have flaccid muscle tone. They're going to be weaker, not going to have as much strength in those muscles to that particular limb, okay? Now, if we have a lesion in C6 to T2, we're going to have lower motor neuron signs to the thoracic limb, so we're going to have short, choppy gait, but upper motor neuron signs to the pelvic limb, so we're going to have a long, slow gait. So when you see this animal that has a short, choppy gait up front, but a long, slow, strided gait, obviously two different rated gaits between the front limb and the back limb, they call that a two-engine gait. So if you see a two-engine gait, start thinking this lesion might be in this C6 to T2 area because I've got two different rates of movement. Now you have to be careful when you evaluate that because any lesion that's in the T3 area or lower is going to, or T3 to L3 can also cause a slow lumbering gait to the back limbs, but the front limbs will have a normal gait. It's not short and choppy. So it's going to look a little bit different in rates, even with the T3 to L3 lesion, but the gait up front is going to be a more normal, relaxed gait that you'd expect for the rate at which they're moving. It's not going to be short and choppy. So you have to evaluate, not is there two different rates between the front limb and the back limb, but is the front limb gait short and choppy? Okay, so just keep that in mind because it's something that you should remember for later on in this lecture. Probably not going to be getting until next week though, okay, but remember that. But it's going to be one of those things that's a classic scenario where if you have a short choppy gait at front and a long strided slow ataxic gait in the hind limbs, think about a C6 to T2 lesion, okay? Is that making sense? Yes.
Yes, and I'm sorry, I have another stupid question. Can you remind me what paresis is again?
Paresis is, I'm going to define that in a little bit.
Oh,
It's
I'm
gonna be-
sorry.
yeah.
Okay.
Paresis means decreased voluntary motor or
Okay.
weakness. Okay, the neurologist will debate a little bit difference between those two, but for our purposes, it's going to be decreased voluntary motor or weakness. Okay.
Real quick.
Yeah.
You would never have upper motor neuron in the
Correct, right. Okay. Yeah, and the neurology, the central nervous system is built on a hierarchy. So anytime you have a lesion, the abnormalities are going to be found at the site of the lesion or caudal to it. Okay. You're never going to have a lesion. Well, I shouldn't say never, because I'm going to explain that in a minute. There's going to be one exception. You're not really going to have very many times where there's going to be a lesion and you're going to have abnormalities cranial to that lesion. Okay. So, but you think that the abnormalities will be at or behind it. That's right. That's why we talk in terms of paraparesis or paraplegia. Para means two, okay? And when you see that, it's always the two hind limbs. You're never going to have paraplegia be front limbs are abnormal, but the hind limbs are normal. It's always going to be that lesion or caudal, okay? All right. So that is basically our functional anatomy of what's going on with the three different segments of the brain. Again, the prosencephalon, brainstem, and cerebellum, and then the four segments of the spinal cord. C1 to C5, C6 to T2, T3 to L3, and L4 to S3. And then the associated function of those segments and the abnormalities you can get on with lesions in those areas. So now I want to talk about the neurologic exam. So that's talking about the functional neuroanatomy. We're going to now go switch over to the neurologic exam. The neurologic exam, just like our physical exam, should be done in a fairly logical manner. Do it the same way every time, all the time, so you know that you're being complete and thorough with it, and it becomes familiar to you. It gets to be something you're going to do regularly and be comfortable with, and know that once you find the abnormalities, you got things localized pretty darn good. Okay, so whenever I do my 3 cases at the end next week, we're going to go through all the different steps of the neurologic exam. Those steps basically are history. What are the symptoms? When did they start? How did they progress over time? Now this you're relying on the owner, so be a little bit cautious in interpreting what they say, because they sometimes will misinterpret. So you want to focus on what is it that they observe, not what they conclude is happening. My dog is walking funny because he's overdone it and I think he slipped down a couple stairs. Well, I don't care what you think happened. What does it mean? What do you mean when you say he's walking funny? So you have to focus on their observations, not so much their conclusions, okay? Mentation and orientation of the environment. Mentation means their general attitude, and orientation of the environment, how do they engage the environment around them. Their gait, what do they walk, what does their gait look like, or how is it that they're walking? And their posture, what position did their body take whenever they're sitting, standing, and things like that. Then we're going to go, those are the things that we're going to be, not even having the animal being examined, but the animal's going to be off on its own. We're going to talk to the owner first to get the history, and then while we're talking, or if you want to just separate, stand back and watch the animal. See what are their mentation, what is the orientation of the environment around them, how do they walk, and what does that characteristic gait look like, and what is their posture whenever they're sitting or standing, kind of a thing. So these are things you do without even touching the animal so far. Then you go to the exam where you're going to start to touch the animal and examine the animal. So a lot of people will start with a cranial nerve exam. You can do it whatever order you want, as long as all these categories are done. So cranial nerves, we're going to talk about how we're going to assess each of the 12 cranial nerves, okay? Got to memorize those too, unfortunately. Again, whatever mnemonic you like to use, and there's some really fun ones out there. Postural responsive, which means you're going to put the feet in different positions and put the body in different places and see how the body corrects itself, okay? Spinal reflexes, we're going to look at those reflexive arcs. This is something that does not need the brain to work. You can have a dog that has a complete paralysis in the cervical spine, still have spinal reflexes in the both thoracic and the pelvic limbs. So these are just local reflex arcs that we're going to be checking. Then you have ancillary tests, things like palpation. Is there any muscle atrophy or asymmetry? Is there any spinal pain or discomfort going on whenever you palpate the animal? Talk about the paniculus, or another term for it is a cutaneous trunci reflex, and see if you can't localize where in the spine the lesion might be. And if the perception of pain, now we'll call this nociception. Basically, we're determining, can the animal feel deep pain, okay? And I put that last because that's not something you always need to reach for. Deep pain is a very well-preserved function. And that means it's the last to go. So if you have other functions that are intact, you know, they have intact motor to the limbs, and they also have superficial pain, you don't need to sit there and crunch on their bones to see if they respond, because you know that's intact, because the functions that are going to lost before them are still present. So you don't always do nociception. You only do that whenever there's loss of every other function. You want to see if there's something there. Okay. Now, if nociception or pain perception is also lost, that's a pretty severe lesion. You have to really act on that quickly if you're going to get function back at all. Okay? Alrighty. Now, when we're doing our neurologic exam, it's important to realize that all we're doing is localizing where the lesion is. We really can't tell with our exam what that lesion is. Further testing needs to be done to figure out what that lesion is, and that's usually what the neurologists do, because by the time you're there, you're probably talking higher end types of studies like MRIs, spinal taps, myelograms, things like that, EEGs, to figure out what exactly is the lesion and what it is there for us, okay? So our job is to say, where is the lesion? And then based on these signs, what are the most likely possibilities? But to get a definitive diagnosis, you need the neurologist to take it the next step and do what is the lesion, okay? So we're going to get through as much of our neurologic exam as we can until the time runs out. And when time runs out, we'll just pick up from where we left off next week and then continue on with the rest of the neurologic exam, okay? Does that make sense so far for everybody? Okay, good. All right, history. I love this graph. There's a lot of versions out there online, but it basically tells you, based on the progression of clinical signs, you can already kind of tunnel in certain types of processes being most likely, okay? Now, there's a lot of lines here, but I'm going to kind of group them into just a few, okay? So first we're going to talk about this line over here. That's just straight across. The clinical signs are abnormal, and over time, they don't get worse, but they don't get better, okay? These are usually anomalies, which means you're anatomic defects. Cerebellar hypoplasia, there is a fixed defect in the brain. It's not going to get worse over time. It's going to stay static over time. You have paralysis in one of the limbs. It's going to stay there forever. It's not going to be something that gets worse or gets better over time. So you're going to have your anomalies. It's going to be just static all the way. Okay. Now this curve here is going to be one that we see a lot. It's going to be suddenly worsening of the signs, then slow improvement. This is going to be common for trauma, just down here. Vascular events, so strokes or bleeds in the central nervous system, or infectious diseases that are treated. That's a key. It has to be treated. If they're untreated, then they look differently. Okay. Now you also have these curves here. Now these I kind of grouped together as well, where you have a slow abnormality that over time gets worse and worse and worse. Okay. These are going to be your neoplastic processes or your degenerative processes, so your brain tumors, or you're going to have your degenerative myelopathies. They're going to start mild and then get worse and worse over time. Okay. Then you have these two, which is going to be your ups and downs. You're going to have ups and downs that maybe get worse or maybe about the same, but there's going to be good days, good weeks, bad weeks. And these are going to be your metabolic diseases, like your hepatoencephalopathies. You're going to have waxing and waning signs. You're going to have your inflammatory diseases be waxing and waning, immune-mediated diseases, granulomas, meningoencephalitis, and things like that. Going to be up and down for you with their clinical signs, especially if they're not treated. So based on your history, you can always kind of categorize, okay, this is likely a traumatic event or a vascular event, or this is likely going to be a degenerative process over time because it's slowly getting worse and you only noticed that a few months ago to start. So we're going to already narrow things down with our history. So don't forget about your history. Remember, when we're doing our exams, up to 70% of the information we use to make a diagnosis is in the history. Don't slough through that, okay? You have to really pay attention to that. All right. Mentation. We did cover this a little bit when we did our triage lecture as well. There's going to be 7 different grades of mentation. You're going to be normal, which is bright and alert, okay? You're going to have your depressed mentation. Other terms for this that mean exactly the same thing are obtunded or dull mentation, okay? That means that you're still responsive, but you're going to be less interested, less responsive than normal to the stimuli around you, to the people around you. Then you have your stuporous mentation. Stuporous means that you're pretty much unresponsive unless you have a noxious stimulus. So they're sitting there, they're not even paying attention to you, they don't even seem to be conscious or aware. You pinch their toes and they're going to look up and react to you, okay? Then you have your comatose mentation, which means that you're going to be unresponsive even with a noxious stimulus. So they're basically going to be in a coma, okay, is what that means.
I've always had obtunded used as stuporous for comatose.
No.
Yeah. I was thought obtunded was one
No,
step further.
obtunded is same as dull or depressed mentation, yeah. Dementia, delirium, disorientation, confusion, they all can be the same thing. This means that you have a response to the environment, but it's inappropriate. It's either the wrong type of response, too extreme of a response, or a confused or distorted response to some stimulus that's in the environment for us there. Now, if you do have altered mentation of some sort, that usually is translated to a prosencephalon, a forebrain type of a lesion. So whenever you see that, you're already looking up into the forebrain. Sometimes brainstem is a possibility as well, okay? All right, orientation of the environment. This is how do I engage the environment around me. So you're going to see things like circling, large circles, usually in one direction, and that usually is toward the lesion of the cerebrum that you're seeing it. Hemi-neglect, hemi-inattention we talked about. Head pressing. Now head pressing you can't tell aside, it's just prosencephalon and forebrain. Compulsive pacing or aimless wandering. This is common for cats. Most cats are going to cower or stay in one spot in the room. If you see one that keeps on pacing and pacing and pacing, that might be a cat that has a prosencephalon lesion. So kind of be a little bit aware of that one for you. And all these orientation alterations in the orientation environment are usually forebrain type of lesions. Okay. Gait and posture. Going to spend a few minutes with this. Gait is going to be characterized. Is it going to be ataxic, which is incoordinated? And we're going to talk in a minute about there's several types of ataxia. 3 types in particular. Paresis, which is again decreased voluntary motor or weakness. Again, neurologists debate that there's a difference between these, but for our purposes, they're pretty much the same. They're weak or they have decreased control over their limbs. Okay. Paralysis, of course, is a complete loss of voluntary motor. Or is there a lameness? Lameness is not always an orthopedic lesion. If there is a lesion in some of the nerves to the brachial plexus or to the pelvic plexus, those can show up as primarily painful, and they'll be lame, and it's really a neurologic origin. So lameness is not always just an orthopedic lesion. Okay. Now posture, a few specific postures you want to be clear. We already talked about the head position, which is difference between a head turn, which means the ears are level, but the nose turns from side to side, or the head tilt, where the ears are going to be turning unequal, but the nose is still going to be straight. Okay. Body position, sit, standing, recumbent. Okay. Spinal curvature, and we're going to go through the different types of those as well. And then we already talked about the decerebrate and the decerebellar postures whenever we talked about the brainstem and the cerebellum respectively. One other one that we want to talk about with posture is called Schiff-Sherrington. And I'll go through that in just a minute as we get through that. So we're going to go through each of these, go through a little bit more detail with these until we run out of time, okay? So I'm going to have one of you guys help me remember exactly where we left off so we can be sure we pick up from that. Now for the ataxia, there's 3 different types of ataxia. The one that we're most familiar with and we'll most commonly see is going to be proprioceptive ataxia. This means the patient does not know where their limbs are in relation to the body, so they place them in abnormal spots, okay? Usually whenever you see this, you're going to have a wide base type of stance because they're going to be a little bit less certain of where they go, so they're going to take the caution to have a more wide base stance because it's more stable. They're going to have a swaying type of gait. A lot of times they'll be crossing their legs, especially whenever they turn in circles. And there's going to be scuffing or dragging of the toes whenever they bring their leg forward in their gaze. Okay, so you can see those kind of things. Now, whenever you see this, the postural response is going to be abnormal. So when you do the knuckling and see if they're going to correct their paw, or if you make them hop or wheelbarrow or hemi-stand or hemi-walk, you're going to find that there's going to be postural deficits when there's proprioceptive ataxia. Now, because this can be sometimes a little bit hard to visualize, one of the neurologists I heard a lecture from really made it nice. If you look at the dog in line with their spine, so their head is towards you and their back is away from you, or vice versa, and you watch them walk, you're going to see that the legs move abnormally, either away or towards the midline, and then the trunk follows. Okay, so they're placing their feet abnormally, and it draws their trunk offline. Okay, as opposed to the vestibular ataxia, what we'll talk about is a little different than that. Now, if you do see proprioceptive ataxia, there's a long pathway of nerves that can be controlling proprioception. And so that could be anywhere from the cerebrum, brainstem, spinal cord, or the peripheral nerve going down to the muscle. So it could be anywhere in that area. So we use other tests to determine, is this something that is in the brainstem, or is it in the cerebrum, or is it in the spinal cord? So you need other tests to know where it is. Okay, these are long tracks. Vestibular ataxia basically means you're off balance. Okay, so these will a lot of times be accompanied by a head tilt. So the nose is straight, but the head's tilted off to the side towards the lesion that's there usually. There's nystagmus, which is abnormal eye movement where the eyes go back and forth. There's usually different rate between different directions. So it'll be one direction be slow, next direction is fast, and it's usually consistent. The fast phase is usually away from the lesion for something like this, and they're turning or falling to one side. So they're going to keep turning and falling over to that one side. Some dogs that are really bad actually roll across the floor. Okay. Now in this thing, the key with this is you're going to have normal postural responses. So they're going to be off balance, they're going to be falling, but when you hold them steady and you put their feet in abnormal positions, they're going to always respond properly. They have normal postural responses. Okay. Now, as opposed to the proprioceptive ataxia, where if you're looking at them in line, the feet go abnormal, pull the body off. Of proprioceptive ataxia, here the feet are properly placed, but the trunk goes offline and it pulls the feet with them. Okay, so that's another way of thinking that this is proprioceptive versus vestibular ataxia. Now the third type of ataxia is going to be what's called cerebellar ataxia. And we already talked about some of these things where you're going to have increased range and force of the limb movement. So it's going to be a lack of the coordination of the intentions of the movements for us. Now here there's no paresis. They still have full control of their motor functions. It's just inappropriately placed, okay, or inappropriately magnitude. It's too big or too small, okay? Now here you can have, like we talked about, increased flexion of the elbows or increased flexion of the knees. So your carpi and your hocks are going to be having a lot of big movements whenever there is cerebellar ataxia. And this increased flexion of the elbows and the knees is what distinguishes these exaggerated movements from, say, an upper motor neuron lesion in the spinal cord, okay? You can also get things like intention tremors, treble sway, vestibular signs that we've talked about before. Now in the cerebellar lesion, if you have vestibular signs, the lesion is usually opposite of the head tilt and the falling over. Now we're not going to know that without further information, but just so you know that in the cerebellar lesion, if there's going to be falling or vestibular signs, the lesion is usually opposite. Okay, there's some exceptions to that, but it's usually opposite. Okay.
We have 4 minutes.
Okay. How you guys doing? You guys want to stop here, and we'll talk about other things here a little bit. This will take real quick with the presence paralysis. Then we can talk about posture coming up next time. Does that sound good? Okay. Now this is more just terminology. Paresis again is a weakness or a partial loss of motor control of the body, okay? Plegia means paralysis, a complete loss of voluntary motor. Mono means that just one limb is affected. Para means both limbs are affected, but it's only the pelvic limbs. Para always means pelvic limbs, PP, okay? Hemi means 2 limbs, but on the same side. And then tetra means all 4 limbs are affected. So for example, if I say an animal has a left-sided hemiparesis, that means both the left front and the left hind legs have decreased voluntary control or weakness, okay? A paraplegic means that both pelvic limbs are paralyzed. And then if you have a quadriparetic animal, this is going to be an animal with all 4 limbs are going to have a weakened or decreased voluntary motor to that. Does that make sense for the terminology? So you can be exact as you can. So I've got, okay, proprioceptive ataxia with paraparesis means that the both back legs are going to have in coordination because they don't know where their feet are, and decreased motor control as a result of it. Okay? Is that making sense for you guys? Okay, cool. So we'll stop here for today.